remember when we said that the primary objective is what decides the study design of your project. So to examine the prevalence of and factors associated with persistent pain after surgical treatment of breast cancer, the design, you remember this is the methodology section. It says a nationwide cross-sectional questionnaire study of 3,754 women aged between 18 to 70 years who received surgery and adjuvant therapy for primary breast cancer in Denmark between January 1, 2005 and December 2006. A study questionnaire was sent to the women between January and April 2008. So, this makes it a cross-sectional study, first because they selected a group of people and they sent them the questionnaires. They did not decide whether the patient is exposed or non-exposed or has the outcome or not having the outcome to be included in the study. So they took the whole group, which is the sample, and they gave them the questionnaires and they collected information on them. So this is the outcome as they provided into the paper. So how many people did they include? 3,187. It's less than the number that's reported in the abstract, maybe because of some missing information. But here I'm talking about chemotherapy and I'm talking about the outcome. Okay? This specific table is targeting the effect of chemotherapy on the outcome, which is pain or no pain. Okay? How many patients do I have? It's 3,187. How many patients who had chemotherapy? I have the total here, 1,220. How many patients did not have chemotherapy? It's 1,967. 664 patients who had chemotherapy and have pain. 556 who did not have, who had chemotherapy but did not have pain. Now, this is a summary of the results, but now I have to make a conclusion. Is there any association between chemotherapy and the outcome or pain or not? So what I do is I calculate percentages. What does it mean? The way I look at this is among those who have chemotherapy and those who do not have chemotherapy. I have two groups, a group who had chemotherapy and a group who did not have chemotherapy. So I calculate the percentage or the prevalence of having pain in each of these two groups. So I can calculate the percentage. To simplify this, I'll just do a table with easier numbers to calculate. So assume that I have the chemotherapy yes and the chemotherapy no, and I have the pain and no pain. Okay? Instead of having this number, I will take a sample of 300 people. Okay? So I take 300 people into my study and assume that I have 100 who had chemotherapy and 200 who did not have chemotherapy. I'll give you different scenarios and I will highlight what I want to establish. If I have, let's say, 20 people here who have pain, among those who have taken chemotherapy, there will be 80 here. And if I have 40, I will have 160. I would usually ask a question, which is there any association between chemotherapy and pain in this example? And some people might say yes, because I have 40 people who have pain in this group as compared to 20 people. I would say, no, this is wrong. Why? Because I should not look at the number of people. I should look at the percentage, which is how many people out of how many have pain. In this case, I look at the prevalence. Since it's a cross-sectional study and it's descriptive in nature, I will calculate the prevalence. So I will do the prevalence of pain in the chemo group. What would it be? In this chemo group, I have 100 people. How many have pain? It's 20 over 100. It will be 20%. Okay? I will calculate another prevalence, which is the percentage of pain in the no chemo group. It will be 40 out of 200. And it will be, again, 20%. So you can see that whether a person has chemotherapy or does not have chemotherapy, she has the same chances of having the pain. This is why I will conclude that there is no association between chemotherapy and pain. How do I justify or how do I illustrate this? I calculate something called prevalence rate ratio or prevalence ratio, where I divide these two numbers by each other. So if I divide these two numbers by each other, it will be what in this case? It will be 1. So any value of 1, it means that there is no association. Now I'll give you another scenario where instead of 20 here, I might have 40. So in this case, I'm left with 60. And the prevalence rate ratio now would be 40% over 20%. So I can see that if a person had chemotherapy, she has more chance of having pain. So there is a positive association. So as people take the chemotherapy, they will have more pain, and this will be equal to 2. And a prevalence ratio of anything above 1 would indicate a positive association. All right, so the second point, assume that instead of 20 here, I have 10 patients. So instead of the prevalence in this people will be 10% over 40 out of 200, it will be 20%, and thus it will be 0.5. So you can see that those who have chemotherapy are less likely to have pain as compared to those who do not have chemotherapy. And in this case, I can say that chemotherapy is protective against pain. So this prevalence rate ratio, we have established 3 scenarios. One scenario where we have equal prevalences, okay, and thus you will have a ratio of 1, meaning there is no association. One scenario where you have more than 1, meaning one group increases the chances. In this case, it's chemotherapy, have more chances of pain. And the third choice, or the third scenario, where it would be less, where it will be protective. Now, these 3 scenarios are applicable to any study design that we have. So let us take this example now. This example that was published, we found that 664 out of 1,220, which is 54.4%, is the prevalence of pain among chemotherapy groups. So among this group, you have 54.4%. Among this group, it's 879 divided by 1967. It will be 44.7%. I will calculate the prevalence ratio. It will be 54.4 over 44.7, and it will be 1.22. What would my conclusion be? That those who are having chemotherapy are more likely, because they have higher chances of having pain as compared to people who do not have chemotherapy, and there is 1.22 prevalence rate. Now, what are the advantages of a cross-sectional study? Cross-sectional study are cheap. In other words, do you have to follow people up for a long period of time? No. In a certain period of time, you see the patient once, you get the information from them, and that's it. You do not see them again. So you do not have to spend a lot of money on following people for a long period of time. It is fast. Why? Because whenever I have a question, I can design my study, I develop a questionnaire, I distribute it to a certain group of people, get the answers, I will analyze them and get the conclusion. So it is fast, and this is why in this region, most of the studies that are carried out in the medical field are of cross-sectional type of studies. It is simple because it's not complicated in terms of the analysis and in terms of recruitment of patients and in terms of verification of the outcomes and so on and so forth. It is simple. But with all these advantages that we have, we should have a lot of disadvantages. And the disadvantages basically are representativeness. Representativeness meaning that since you are taking a sample, you have to make sure that the sample represents the whole population. Okay? I usually give this example to illustrate the representativeness. Assume that you are interested in getting some information about patients admitted to a certain hospital in the kingdom. Okay? So what is the population? The population is anybody who is admitted to the hospital in this community. For instance, I'm interested in Hospital X, and I'm interested in the patients admitted to this hospital. So what is the population? I will reflect this as population, any patient who is admitted to this hospital. Fine? I will take a sample. Assume that I want to take a sample of 200 patients. I have different scenarios. I'll give you two extreme scenarios to illustrate my point. If I take 200 patients from the ICU department, do you think that this sample is representative of the whole population? No. Why? Because this sample are expected to be sicker, older, and die more frequently, right? As compared, if I take another sample from a pediatric ward, is it going to be representative of the whole population? Also no, because these are healthier, younger, and so on and so forth. So the best way, and this is what I reflected on the sampling. When I want to select a sample, the best way is to select a random sample where anyone in this population have the same chance of being into my study. So representativeness is very important, and whenever you do a cross-section study, you have to make sure that your sample is representative of the whole population. The second thing is failing to take time. Since it's cross-sectional in nature, I see people at one point in time and I do not see them again. I do not know what's happening with them in terms of time. I'll give you another example that usually is a classic example for illustrating time. Depression and cancer. If I'm interested in seeing the association between depression and cancer, and I do a cross-sectional study, what happens is I get information on cancer and I get information on depression. So when I'm doing the 2x2 table, I can conclude on the effect of one on the other. So assume I found the association to be of 2.0, a prevalence rate ratio. You remember the prevalence rate ratio. So prevalence rate ratio was 2. What does it mean? It means those who are depressed are more likely to have cancer, right? But this is a proper conclusion. It might not be a proper conclusion because I do not know whether depression came first or cancer came first. In other words, it might happen that those who have cancer have more chances of being depressed. But it happens also that those who are depressed might have more chances of having cancer. So since my study is cross-section, I do not take time into consideration. I cannot know whether depression came first or cancer came first. So a cross-sectional study does not take time into consideration, and this way I cannot establish causality. I cannot say that depression is affecting the risk of cancer or cancer is affecting the chances or risk of depression. Vulnerability towards biases. Bias, by definition, is a word that's reflected for an error. When you are doing a study, you might be doing an error or a mistake or a bias. And in research, you have three main types of biases. The three main types of biases are, one is called selection bias. The first one is called selection bias. And the selection bias is a type of bias that's due, or it's apparent from the way you select people into your study. So for example, you remember the ICU and pediatric ward, or the selection of the sample. If you select a group of people who is not good, then you have a selection bias. You have another type of bias that's called information bias. Information bias is a type of bias that happens when you collect people into your study, or you get people into your study, but you collect information from them in a wrong way. So your collection, your data collection is not accurate enough. This is why you have information bias. And the third one is a confounding bias. A confounding bias is a bias that occurs when a third or a confounder or a third variable affects my association. In other words, I will leave it up to the end to explain this. But the point is, I have three main types of biases: selection bias, information bias, and confounding. And the cross-sectional study is affected by the three types of biases. I'll move again. Now I'll talk about the analytical studies. And the first type of analytical studies is called a case control study. So what does a case control study mean? A case, by definition, is a person with a certain disease or with a certain outcome. Now, a case control study is a study that compares people with the disease and people without the disease. So I have two groups of patients, people who have the disease and people who do not have the disease. So what I do is, when I start my study, it's not like the cross-sectional study. The cross-sectional study, I take a group of people and get information on them. In a case control study, I get people according to their disease status or their outcome. So a case control study is when I have a certain population, and of course, time is forward, but the direction of the study is backwards. Okay? What does it mean? It means in the defined population, I take a sample. But this sample is not a random sample among everybody. I take the sample based on a certain criteria, which is the outcome. Does the person have the disease? He or she is called a case. Does the person not have the disease? He or she is called a control. Now, once I establish these two groups, since it's backwards, I have to look into their history. Like 5 years ago, who was taking this exposure and who was taking the other exposure. So in the cases, I look for the exposure, and for the controls, I look for the exposure. So this is the general layout of a case control study. And a case control study is also summarized by this 2x2 table. In this 2x2 table, the same thing, but instead of calculating a prevalence rate or prevalence ratio, I calculate something that's called odds ratio. An odds ratio is calculated by multiplying this number by that number, AD, A times D, divided by B times C. So it's AD over BC, and I will get the odds ratio. The reason why we use an odds ratio is because of some methodological aspect, but the important thing is that the odds ratio is interpreted the same as the prevalence ratio. So an odds ratio could be equal to 1. An odds ratio could be equal to 1, meaning no association. An odds ratio could be less than 1, meaning that the exposure decreases the risk of the outcome. And it could be greater than 1, it means the exposure increases the risk of the outcome. The same thing as the prevalence ratio. Let us take an example. Early life exposure to diagnostic radiation and ultrasound scans and risk of childhood cancer, a case control study. You remember at the beginning when I told you about the title should explain everything about the paper? In this case, it's telling you about the exposure, the outcome, in which group, and the study design, which is a case control study. So when you read that title, you'll be able to see that they have carried out a case control study. So the objective is to examine the childhood cancer risks associated with exposure to diagnostic radiation and ultrasound scans in utero and in early infancy, age 0 to 100 days. The design of the study is a case control study. It was published in British Medical Journal. It's one of the best journals as well. Setting, England and Wales. Look at this. They are saying participants, 2690 childhood cancer cases. What